Welcome back from break. I want to announce that this session of the symposium, Going Viral, Impact and Implications of the 1918 Influenza Pandemic, is being live streamed. So I'd like to not only welcome the audience in the room, but also the virtual audience members as well. I'm Lisa Coonan. I serve as the Deputy Director of the Influenza Coordination Unit at CDC in Atlanta. And our office is responsible for creating, exercising, and updating the agency's pandemic plan. I also have the pleasure of being Adjunct Assistant Professor here in the UNC Gilling School of Global Public Health. I know that your heads and maybe your hearts are full of the stories and the information that we heard this morning and this afternoon. And I just want to invite you to make a little more space, because we have a fabulous session coming up. You've already heard about the impact of the devastating 1918 pandemic virus and the specter of the currently circulating H7N9 virus in China. The importance of One Health, the need for better vaccines and antivirals to fight the flu, the need for clear communication, the importance of ethical principles to guide a pandemic response. And during this session, entitled Aspiring to Predict and Prevent the Next Pandemic, we're going to turn our attention forward. What could be the next pandemic, and how we are aspiring to predict and hopefully prevent it. And in alignment with the theme of the conference, to provide a multidisciplinary view of the 1918 pandemic and the way forward, we have a great lineup of speakers. What we know from history and the nature of a flu virus as it circulates every year is that right now it's very hard to predict the behavior and the emergence of a flu virus. However, there are multiple strategies that we need to put in place in order to mitigate the next pandemic. And our next panel will discuss key issues that must be addressed as we plan and prepare for a pandemic. The global perspective is critical for planning. Multiple methods for early detection of a pandemic are important, and the potential for the economic impact of the next pandemic must be thought about now in order to mitigate it. I'll introduce all 5 speakers first in the order that they will take the podium, and please note that we do have a bit of a change in the order of speakers from prior published order. And because the agenda is so full, I'm not going to be able to do justice to their full bios, so I will give you a very brief introduction. Please also note that when the presentations conclude, there'll be time for you to ask questions, as with the previous sessions. Our first speaker is Dr. Bruce Gellin, who will discuss how global health meets global health security in the pandemic influenza. Dr. Gellin is the president of the Global Immunization for the Sabin Vaccine Institute. He served previously as a Deputy Assistant Secretary for Health and Director of the National Vaccine Program Office at the US HHS, Health and Human Services, where he was a principal advisor to the Assistant Secretary on Vaccine and Immunization Program and Policy. The next speaker is Dr. Mark Holmes, who will bring us up to date on the National Collaborative for Biopreparedness. Dr. Holmes is a professor of health policy and management at the UNC Gilling School of Global Public Health and the director of the UNC's Cecil Shepps Center for Health Services Research, where he also directs the North Carolina Rural Health Research and Policy Analysis Center. He's a health economist by training, whose expertise include hospital finance, rural health, workforce, health policy, and patient-centered outcomes research. Dr. John Brownstein will describe the use of digital tools and citizen science for pandemic surveillance, prevention, and preparedness. Dr. Brownstein is Professor of Biomedical Informatics at Harvard Medical School and Chief Innovation Officer at Boston Children's Hospital. He has been at the forefront in developing and applying data mining and citizen science for public health. Dr. Greg Evans will talk about the intersection of pandemics and biopreparedness and surveillance tools used to detect influenza. Dr. Evans is Dean of the Jingping Su College of Public Health and Professor of Environmental Health. Dr. Evans's work focuses on environmental epidemiology with an emphasis on environmental toxins, bioterrorism, pandemic preparedness, and disaster preparedness. And our final speaker, Dr. Martin Meltzer, will tell us about the economic impact of pandemics and the use of economic tools for better decision-making and pandemic prevention. Dr. Meltzer is the lead for the CDC's Health, Economics, and Modeling Unit and a distinguished consultant in the Division of Preparedness and Emergency Infections. More information about our speakers is available online, and again, we will have time at the end of the session for questions. Now, please join me in welcoming Dr. Bruce Skelling.
Taking the timer? Oh, fresh timer. Thanks a lot, Lisa, and it's a particular honor and privilege to have a talk entitled Global Health Meets Global Health Security when two of the sponsors are the Gilling School of Global Health and the UNC Institute for Global Health and Infectious Diseases, so I know they're watching carefully. But I think you're going to hear how this ties together many of the things we heard this morning and also fits in with what Lisa outlined as this interdisciplinary session this afternoon. So this is a lot about risk and managing risk, and that's what we've heard all day today. This is a published document from the United Kingdom, which they put out every couple of years, that looks, it's called their National Risk Register of Civil Emergencies. What I didn't put here was the picture of the minister of whatever cabinet department who puts this out, who had this very smiling face. Like the woman in the elevator that signs up in all the North Carolina elevators, it sort of had that look, and I'm thinking, how is this person so cheerful when you look at all the things she has to worry about? But what I want to point out is that of all these things, and they have a separate table for all the bad guy stuff, but of all those things, natural and bad guy, the thing that worries them the most is pandemic influenza. I think from a politician's standpoint, they can't put anything in the right-hand column which says likelihood of happening within 5 years, because nobody wants to confess that they actually know that. So there's nothing in that column, but the impact and the severity is the y-axis, and there's nothing higher than that on either of these tables. As the congressman told us this morning, this is a public health issue, but also it is a global issue that gets beyond public health. And I think that's why it's important to look at this through another lens besides just public health. And this comes from the World Bank that looks at this from that perspective and tries to sort of to balance some of the things we've been talking about before, is making the investment case for these catastrophes. And from the bank's perspective, if you had the 1918 pandemic today, it would amount to almost 5% of GDP, or more than $3 trillion. So those are the kind of things that people have to look at when they think about where you're going to put your money. Also, the congressman talked about the number of federal departments that are involved in this. And this is a document from the Department of Homeland Security in their document on who should get pandemic vaccine when there's not enough to go around. And for this exercise, there is something called the critical infrastructure, which is the part of society, mostly private sector and some public, that needs to keep things going. And there's a lot about different sectors of the critical infrastructure. They're all depicted here, and you can see how interwoven they are. Another ethical issue is who gets to go first and who gets to go last when there's not enough to go around. But this is to show how interconnected these things are when a public health threat spills over into both an economic and societal threat. So back to the history of this country, which was just and this is a document from a few years after the history of this university. This is the Act for the Relief of Sick and Disabled Seamen, which is the beginning of the U.S. Public Health Service. The reason that this was important, because in a new nation, commerce was dependent on the nation's economy was dependent on commerce, which was critical on the movement of ships. We already heard in the situation in North Carolina how ships landed in Wilmington and then brought virus into the state. But it was keeping the merchant marine healthy was the most important part of the nation's economy, and hence this act for the relief of sick and disabled seamen, which began the hospital system, which many of you know about, that were built around coastal cities. What probably you may not know is that the way they raised money for this was to raise 20 cents per month deducted from all the wages of the people on these foreign voyages. So probably in another session that you'll have here about the U.S. healthcare system, This is probably the first sign of the individual mandate. We won't talk about that here. But as Howard Markel told us, the parts of the origins of infectious disease control, particularly at the time when the germ theory was still a theory, was the role of quarantine. And so it's not a surprise that the flag for the U.S. Public Health Service is the color of the quarantine flag. I didn't know that there was a dinner flag. I'm not a sailor. I've seen the skin diver flag before, but you can see how much the history of public health in the United States is based on some of these principles. And while we're here talking about pandemic influenza, if we were having this conference 100 years ago, which I guess UNC had a conference center then, it may not have been quite like this, the same issue would have been about cholera at that time, because the cholera pandemics, and there have been 7 of them that started in the early 1800s, were the thing that kept these people healthy, awake at night. And as you can see, the concerns then were the same now. Cholera outbreaks cause panic, disrupt the social and economic structure, and impede the development of affected communities. Unjustified panic and reaction by other countries curtail travel restrictions. And then something about food because of cholera. But you can see the themes are the same about the movement of people and the germs that come with them, and the need to try to balance that and the spread of disease with national commercial interests. And then comes the first sanitary convention. So somebody will know, one of your historians will know, when the sanitary stuff started to be called public health, but in the previous era it was all about sanitation, and largely because of water and sewage, and largely because of cholera. So the first convention, the International Sanitary Convention in Paris in 1851, was to do that, to look at maintaining national commercial interest and preventing the spread of cholera, and you can see the tensions in keeping that balance. The 12 countries who were represented, as you can see there, and my history taught me something here, that 4 of the 12 countries were the Italian Papal States, but for each country there was a diplomat and a physician who came to the table to discuss this around cholera. And to put it in historical context, this is 4 years before John Snow took the pump handle off the pump in London. So again, the germ theory is still a theory. Bacteria are maybe seen but not fully understood. Contagion is barely understood, and this International Sanitary Conference is about this issue of national and essentially the beginning of global health security. Wind the clock forward, and we have what's called the International Health Regulations. So the dozen or so of those sanitary conventions became later on the International Health Regulations, which was updated in 2005. And this was approved by the World Health Assembly in 1995. It took 10 years, and you can imagine the kind of conversations that went on, given the balance of national sovereignty, commerce, and health, and the different balances there. It took 10 years to issue these updated regulations. And again, it's a balance of risk assessment and risk management, with the overriding principles being to detect things. Once you see them, you had to figure them out and analyze them and assess them. You had to report them so people knew it was happening, and then there needed to be a response. And you can see how critical all those elements are, and you can also see from a nation's perspective why they might or might not want to participate in some of those things, because if all of a sudden you say you have something bad, that may have implications like it did in the cholera era on travel and trade and commerce and your economy and all the things that go with it. So everybody know this initial? Everybody know these? So the public health emergence of international concern. I guess the people who work for WHO don't start with the acronym. Something snazzy. Fred told us all these great acronyms in the antiviral studies. They don't do that there. So this is public health emergence of international concern, but that was defined in these 2005 international health regulations as a way to actually define this, so that they gave nations the definition of what they needed to report, and it also gave them the safety that they could report things to WHO and have a conversation about it before things would blow up and have implications on travel and trade. And so it does question the degree of full transparency, but at least it encouraged the WHO, the countries around the world, to report to WHO of what was going on. I was with somebody at WHO earlier this week and heard a statistic that I'd never heard before, that they are the global ears for this. We heard about these emergency operations centers. Every month there are 5,000 signals that they hear, 5,000, from around the world. Of those 5,300, they get enough information that they look into them, and 30 are investigated to some degree every month. One of those was Ebola. You never know the next one of those, but to give you a sense of what the traffic looks like in that Emergency Operations Center in WHO, that's the incoming. Probably promoted by having countries report, but better to do that than not. So coming from that is the recognition that if you want people to actually know what's happening in their countries and to be able to do something about them, they need to have capabilities to do that. Tom Frieden is going to talk about that more tomorrow, about the need for some of these national capabilities and capacities. But I wanted to just highlight two of those. Again, here this is what's called the Global Health Security Agenda, which is trying to get the global health, the international health regulations to actually work and having the capacity to do that. So detect, prevent, and respond. I want to focus on just a couple of these aspects and the implications they have for global health security, focusing on surveillance and reporting. So you may have remembered this story. This is the avian flu era. Sorry, I got that wrong. This is the bird flu era in 2005, and this was from the New York Times, where Indonesia says, sorry, we're not sharing our viruses. And the reason is they said, unless you guarantee us access to vaccines, we're not playing. Why should we be giving you these vaccines if we get nothing out of them? Everybody else gets them, the companies get rich, what about us? So that was again, another ethical dilemma, but that was the beginning of a discussion about viral sharing. I think, and I've had this conversation with CDC before, there's no upside to naming a virus after a place. Because if you live there, you don't want your place named that. And in this situation, who would know that it was from Indonesia or some other place if they named it X17B12 or some other thing where that. But these viruses, the nomenclature of influenza and many of these diseases, you name things after either where they're found or the person who wants the Nobel Prize who puts the name on it. But this was really the first time this came up as an issue and was the major departure from free virus sharing before. That led to one of these 4 or 5 year negotiations, which was called the Pandemic Influenza Framework, which is essentially to take on the issue that Indonesia raised is, okay, if sharing is important for risk assessment and therefore for risk management, let's make sure that there's some tit for tat here. And so the Pandemic Influenza Preparedness Framework was designed to do that with pandemic influenza in mind, so that there is now a global architecture for reporting viruses, sharing them, and ensuring that there's some capacity for sharing of the benefits of those viruses, and benefits is defined in a number of ways, from viruses and vaccines, to participation in research, to being named on a paper and the like. But that was, again, a long discussion about pandemic influenza because of its unique risk on virus sharing. But that's the only microbe that has a special framework like this. In 1992, the Convention on Biological Diversity went into effect, and it was about conserving biological diversity. And again, as you can see in the third bullet, it was again about fair and equitable sharing of these benefits. So you can imagine all these things. So if you have tree bark in the Amazon that's going to cure cancer, you want to make sure that somebody doesn't come in and take all your trees and do something with that. But it's also important to know that microbes are part of this. So if you find a microbe in some place, that place says it's mine, there's national sovereignty on it, and again, the same discussion about sharing benefits and sharing access, and you can see already the implications this has for global health security if real-time surveillance and real-time reporting is important, because if you don't have things to analyze, you don't know what's going on, and you could be way behind the curve. So this complicates the rest of biology because we have a special treaty for flu. So let me flash forward. We've heard a little bit about this from some of the speakers about another H and another N. This is H7N9. And you've seen this graph earlier about the sequential wave since 2013. And again, think through of the importance of looking at that virus. Yoshi already talked about this, that Mother Nature had already done some tricks with this virus, and therefore highlighting the importance of understanding what the virus is doing to know whether or not you can do something about it. And so that, again, it reinforces the importance of timely sharing, to do the analysis, to then go on to think about response. And so these are the kind of things that have to be looked at when you're looking at this assessment, not just the virus, but looking at population immunity broadly, and the transmission in animal models and viral susceptibility, the things that Adolfo and Yoshi already talked about. Those are the kind of experiments that they do to try to sort some of these things out, and knowing whether or not things have changed or not, or if this is why the last wave looked worse than the ones before. Is it just because of more reporting, or has something else changed about the virus? So a year ago, because of these sharing of samples, was the recognition that, in fact, as Yoshi said before, the virus had changed. And the federal government, and I was part of those tables before, that had made a stockpile of H7N9 vaccine because it was the biggest current threat, pandemic threat. That stockpile essentially was not going to work against the now drifted virus. So again, the importance of the surveillance, the importance of reporting, the importance of sharing this information so you can make an assessment, because had we assumed that the vaccine that we had in a stockpile was going to be the answer, and we had to go use that to put out a fire somewhere, it wasn't going to work. So again, Yoshi talked about this before, about Mother Nature's probably better than some of the scientists on these, and this piece from the New Yorker, again from the bird flu era, highlighted that. But I also wanted to bring out the attention that was also brought out today, that in the post-9/11 era, things were different. So this is an unclassified report from the CIA. It was online. I didn't have it in my file. That really highlighted these same things. These same science and these same molecular tools that you heard about from Yoshi and Adolfo, the concern is, what if the bad guys get hold of those, and can they do bad things with them? And so you can see this tension between the advancement of science with some of the tools that they talk about and the potential for risk, and therefore a global health risk. So with that, there is raised this whole set of issues about biosafety and biosecurity, and whether or not these kind of experiments were good to do or not. You heard a lot about today about the advantages of those experiments and what we learn from them, and the potential they have to teach us things about developing new diagnostics and vaccines and therapeutics. But then there's the question of the bad guys. And related to that is the question of, should you publish? I think it was earlier this year or last year, there was a published study of the synthesis of the horsepox virus, a cousin of smallpox. So now there's a recipe in the literature where, if you know how to do it, I guess you can go off and do it yourself. I don't know if there's enough information to do that, but that's been the concern about the advancement of the science, and yet not broadcasting it so that anybody with a lab can figure out to do it. And that's part of this debate, which I just wanted to make sure you saw that in the context of global health security. So this dual-use research of concern, another acronym that doesn't roll off the tongue, is about these things, about the kinds of techniques that are going to be good for science, but in the wrong hands might be bad. The gain-of-function research to take a virus that's not so bad and make it worse, or to make it aerosolized. And then this idea of doing the same kind of thing, making things, giving them potential pandemic potential. And you can see the risk that's been raised about that is, should either they get in the bad guy's hands, or should they get loose because of a lab accident? We're not going to discuss that now, but I just wanted to raise that because that's within the context of global health and global health security. That's part of the conversation. And then the third part of this, as far as the viral sharing, is I want to talk about the benefit sharing, because this is the vaccine part. And this is a 2009 H1N1 era story. This is the snapshot of where influenza vaccines are made in the world, and you'll see pretty quickly that the wealthy countries have vaccine production to some degree, but only a few do, and the rest don't. So it raises this whole question about equity of some of these sources. And so in the United States, when we saw this, particularly in the context of 10 years ago when there was a flu vaccine shortage because one of the two suppliers had a contamination, it showed our vulnerability, and we spent a lot of money. $8 billion went into a supplemental budget to do all kinds of things. Most of it was vaccine related. You'll be glad to know your tax dollars went into federalizing chickens, so we now have a federal supply of eggs. And just around the corner in Holly Springs, and I think that David Price was probably there at the ribbon cutting, is a factory that makes influenza vaccines in cell cultures, again with national self-interest. Then it raises the question about what are we going to do about sharing, and I'll talk about this just in a second. But in 2009, as you've seen this before, that the vaccine came long after the virus. Tom Frieden used to joke that there's probably an hour there where it looked like where it crossed over, that it really was important. But again, we need better technology to get the vaccine in front of the virus, not the other way around. But you can quickly see the importance of timely surveillance and reporting to that end, because the earlier you can start, the more you can shift that curve. But I want to put this in the global context as well, because lots of countries, as you saw, were without. And so there was an effort led by actually President Obama, and got a number of his friends to pledge that we would donate vaccine to a global stockpile. And you can imagine the politics of that. There's likely to be a shortage, but we're going to give up some to other people. And other countries had to do the same. And the discussions in the White House were essentially between the domestic policy people and the international people. The domestic people said, hey, they don't vote. And the international people said, yeah, but it's a global society. The upshot was that the U.S. donated 10% of its vaccine supply, and a number of other countries did the same to WHO. But I just want to look at the calendar here. So in the U.S., we started delivering vaccine in October, and in the vaccine that we and other countries donated didn't get out the door until January. So the virus has already taken a wave or maybe two around the world. It took another year for it to get out there. You can see the relatively few doses globally that went out. And again, it raised the question of global equity. That's obviously another global health security issue. And I'll end with this, just to recognize that this is, again, not just a health issue, but this worked its way to the top of the UN. A report from the Secretary General in 2016 that highlighted this. There was a lot of post-Ebola gnashing about this, and this is a part of that. And it recognizes that we've underinvested in what we need to do, and global health and global health security is in our global interests. So thank you for your attention, and we'll talk more about it later. Thanks.
Good afternoon. So I'm talking about the National Collaborative for Biopreparedness, which I understand I missed this morning. I had other engagements, but Congressman Price made a reference to. And this will be an example of biosurveillance systems that we'll also hear about later in the session. So just a brief overview. We'll talk a little bit about the potential of biosurveillance systems with a specific example of NCBP, and then frame it in terms of detection of threats to the biosphere, as well as how it can enable analysis. So systems in general, and this is sort of another dual use in many ways. We've heard a lot of references to Homeland Security, for example, and the biopreparedness from that standpoint. After September 11th and anthrax, there was a fair amount of interest from the Homeland Security defense side of it to detect biological threats. Meanwhile, public health doing what public health does, moving forward with on their side as well. And building off some of the early successes of NC Detect locally, as well as Be Safer from New Mexico, and other systems like this that really gathered information from administrative data sets, whether it's hospitals, emergency rooms, EMS systems, poison control, gather data to provide this near real-time capability of monitoring the biosphere. All this, of course, is complementing the CDC and BioSense and Essence and the efforts that have been done there. So the point I'm making here is that there's a panoply of different biosurveillance systems that are out there. I'll be talking about one. We'll hear more about other kinds of approaches. And there's really, I think, the idea here is that they're all complementary with different business models, and all come down to the same idea. Can we find the signal in the noise from administrative data? So a brief little sense of how NCBP is organized, which is a little bit, I think, different than many systems, and explains a little bit of the way that we're setting it up. Two-sided business model where blue represents sort of the state and local data owners, and you could think of this as EMS agencies, poison control, hospital systems, so the people with the data. Green representing federal subscribers, those with a national mission or a broader mission to really understand what's happening and monitor. And so focusing on the blue side, why should I contribute my data that I'm collecting, and what should I do for it? Well, I submit it. The system extracts symptoms from it, looks for patterns, provides tools that enable it to be more maybe user-oriented and action-ready. From the green side, the federal with the bigger lookup, what are they getting of it? They're getting the local submissions, but they're getting aggregated data. So maybe not the narrative, maybe not the specific case reports, but enough to see that, we're seeing a lot more of this in this area over the last few days. That's something we might want to check out. Let's build a capability for 2 neighboring jurisdictions to talk to each other, these kinds of ideas. So the way that our system is organized currently is that it's a cooperative agreement with DHS and the Countering Weapons of Mass Destruction office, which normally when we talk about flu, they kind of look at you funny, but based on what we've talked about here, we understand that from that standpoint. About 14 million records in the system, covering about 1/6 of the United States, near real time, with a lot of the syndromic classification coming off natural language processing from the narrative from the EMS description. Overlaid on that are motor vehicle crash records, trauma registries, and other administrative data sets. Weather, there's some weather data that gets filtered in there as well to provide as much context as possible to what's happening. So let's give a sense here of what these systems, what these kinds of systems, some of them can, what examples of what they can be used for. So here we have 3 different states, Kansas, Florida, and Arizona, and looking at the influenza-like illness pattern over the past 6 months or so. Again, this is all EMS, and so it's different from other sources as well. But you can see here, I spent probably way too long to try and to separate those lines in the line graph into the different, whether it's local, whether it's regional, whether it's widespread. But you can see as they get thicker, they're darker colors on the CDC flu map. Population pyramid, so you can see, what the flu looks like, and in general, we know it's an infant and elderly with primarily kind of pattern. Often they'll show some sort of event counts, and so you can see an increase in, again here, seasonal flu, of course recognizing that. Bar charts representing the number of cases over the last, this case I guess about a year. You can see that seasonal flu picking up, and also some sort of alerts or anomaly detection as well, in that this chart on the bottom is organized by week. The size of the bubble is how many counties had an unexpectedly high rate of influenza-like illness. And you can see that, a lot of small pinpoint dots in the May through September angle, and then as you get there, I've covered it up there, but, just after that January one, a really big blue blotch. And so it's set up so you can see sort of the trend as well as some statistical anomaly detections behind it saying, hey, this one's surprisingly high, why don't you go look at it? In this case, it's built on influenza, but other syndromes you may be interested in could be in there as well. So that's sort of on a passive standpoint. So the vision here is someone in public health or something like this can be looking in and seeing what's the trend look like, what do I need to look at, what about an active situation? And so as Lisa mentioned, I'm an economist by training, so I drew from my vast clinical expertise here, WebMD.com, looking at an MMWR report on yellow fever from a couple weeks ago, saying that there's yellow fever in Brazil and we need to be wary of it, basically. So this is on a Friday afternoon, so I went into a search into the system and said, show me at least 2 of the following, any EMS call with 2 of the following: fever, nausea, vomiting, body aches, faintness, and with Brazil or America in the narrative. So the idea here is that someone would say, I have a fever and I'm feeling weak and I just flew back from Brazil, and that's something we'd want to hear about, right? So you can enter that in. Here are the 6 cases that flagged based on this description in the data in the system, and you can pull up the narrative and look at this. And in this case, again, based on my vast clinical expertise, this really, although patient is here on vacation from Brazil, there seemed a lot of other stuff there, and there was some denying of it. So this is the kind of principle we could be looking at when the question of, okay, we're seeing that, some sort of novel, infection happening in, pick your favorite part of the world, searching for maybe the history taken by the paramedic or EMS tech, and doing these kinds of narratives in near real time. And this took 10 minutes for me to do, to look what was happening in the back. In terms of digging deeper, so I'm not sure, is this going to work with the clicker? Nope, I'll try it again. But here is I don't know how to animate it, but if you could imagine, close your eyes and imagine the map animating with the darker colors sort of starting from, oh, here we go. I'm using psychokinesis or something here to make it happen. But, you know, the pattern here this year was basically emanating from Louisiana, and the darker colors turning orange to red and sort of spreading out from there. No one in here should be, even the economists should be surprised that, you know, a lot of this stuff spreads to nearby places. This is, you know, Tobler's first law of geography. Near places are more alike than far places. And so this idea that things are correlated in time and space can be applied to other threats, not just the flu. And so I mentioned that the system that we're implementing is being built on basically the goodwill and the value of local jurisdictions to say, what am I going to get out of it? So opioids, of course, are what a lot of local jurisdictions are worried about. Imagine, if you will, if we would be able to detect the spread of, say, fentanyl-laced heroin, for example, or an emerging, a particularly novel, you know, biothreat in the opioid space. So there's a piece a couple months ago, I think in Wired magazine, that says in Baltimore that when they have a spike in heroin overdoses in Baltimore, they see it in West Virginia 18 hours later, because that's how the product moves, if you will. So imagine, so we can look in Florida and see a very similar pattern. If you look at these blue circles are the area of Duval County and Jacksonville, and then the purple color is the day later, and you can see they kind of start moving westward down I-10, black one day later like that. I see, basically, if I squint a little bit, and these are all sort of poor man's heat map with a moving average kind of idea geographically, this sort of blotch moving westward down the interstate, which is what we know about how opioids get transported. So we can use the same sort of principle using these biosurveillance systems to look at spreads of influenza, or the new influenza, or any emerging threat from that standpoint. And looking at not just how is it entering or how is it spreading, but also tracking prophylactic measures or mitigation measures. So here's another way to represent it here. The darker colors on the red colors on the map show the degree to which how many days later we see an increase in overdose rates, and that I'm not from Florida. Is that a knuckle? I don't know what you call that part of the peninsula there. But you know, a day or two later after that, the Jacksonville increase, and then on the right, the darker colors there, green, are more positive. So it's a strong correlation that's occurring a day or two later. So, of course, with influenza in particular, when we've talked about this in the past, people have always said, okay, well, I really am interested in separating a seasonal flu from something that's more emerging or more novel, and that's certainly appropriate here. So a lot of the biosurveillance systems, or I shouldn't say that, but many biosurveillance systems are built on the principle of what happened today, is it different from what happened yesterday or a week ago, and basically looking for short-run changes. But for a lot of these, we have some predictability in it based on what we've seen in the past. We know that flu goes up in the winter. I mean, I can put my money down and bet that December in 2018 will be higher than July or August kind of idea. So let's use historical patterns that we have from these data. We can use a regression-based tool, make it syndrome-specific, compare the actual rates to the predicted, and see where are they really different. We can bring in all kinds of data. We can bring demographics of the county. We can bring in the weather. We can bring in the month of the year. We can bring the day of the month if we're interested in some sort of end of the month kind of pattern there, or paydays in the first or second of the month. You can apply these to specific populations, et cetera. So here's the case in Arizona, and this dashed line here represents respiratory illness. And these were the regression trend based on national patterns with month, weather, et cetera, all the different elements occurring there. And so this dashed line represents the trend of what we would expect in a statewide Arizona. I think this is a 5-day moving average from the period of September 2017 to February 2018. Now, I've already sort of, what's the opposite of buried the lead here, but shown you what the punchline is going to be with this red line here. Back in mid-December, the Thomas Fire out in Southern California was enormous, and we all saw the videos of the conflagration of Los Angeles as you're driving in. So let's compare this dashed line, which represents the predicted based on what we know about respiratory illness in general and the EMS cases for it, This dark black line represents what we actually saw, and then we can just look at the difference. The red line, the red area represents those areas where the actual was much higher than predicted over a long period. The green represents where it was under, and we can see here that from September through early December, roughly about the same, not much difference, up until that mid to late December where that red blotch gets really big, and even I can see that. And so this might be the kind of thing where you go, well, okay, something's going on here. We've detected this occurrence of some event that has really signaled a change here in detecting that. So this, again, same sort of idea. Once we can bring in, not just looking for anomalies, but it allow us to predict it in the future, and use that for more real-time sort of detection. So 3 points, you always end with 3 is what my mentor always tells me. These systems offer near real time, and they have different data footprints, different missions, different audiences. They all have different kind of approaches, but they all will offer this kind of idea that we're looking for here. How can we more quickly detect it, something like this in the future? Most of them are designed to be sensitive rather than specific, and that is, hey, there's something to look at here rather than definitive, and what we want, I think, a lot is the human element to look at it and judge it and say, okay, no system's going to be able to say, well, the reason we see this big red blotch in Arizona is from the fire. You have to bring in that context of what's going on, or why is there a spike in alcohol rates in Daytona Beach in March? There's not, but that kind of thing to bring in that kind of idea. And one more mixing metaphors here, about arrow in the quiver that we can use to detect and manage novel threats in the future. Thank you.
All right, great. Thank you so much. Great to be here. And I think this is a good sort of follow-on from the previous presentation in that we're talking about new data sets, new methods to think about emerging infectious diseases, and new technologies to help support both understanding of what's happening in a population, but also how to support interventions. So I'm going to be telling you a little bit about new sort of data sources that have sort of come into focus probably in the last decade. This is basically a map of the emergence of Zika across the Americas. A map like this could not be constructed with any Ministry of Health, any government agency, WHO, because of the lack of infrastructure for data collection and monitoring, and also the lack of interoperability between systems that exist. And the only way you can create a map like this is by tapping into all the vast amounts of data sources that are out there, organizing that information, and making that available. And so I'm going to tell you a little bit about how we're trying to reimagine how public health surveillance is done by an approach that taps into data that exists outside of traditional channels. And so if you think about the weather and you think about forecasting weather, it's very clear that there's an existence of apps that are out there that you can tap into and understand what's happening right now, but also what is happening, going to happen in the future. And this is because government agencies like NOAA make data available through methodologies like an API in real time that allows for methodologies to be built on top of that data and for forecasting to occur. And so when we think about efforts in population health and public health, we're missing all of those components. Of course, we're missing the underlying global sets of data that allow us to know what's happening, but also we have no access to that information. Of course, that limits any availability of a suite of apps that you can tap into to understand what's happening. And that goes for the consumer. It also goes for clinicians and public health. And so our view has been, of course, there's incredible data that's emerging across many different disciplines. But what we're doing is creating a massive set of siloed data sets that lack interoperability and lack the ability to tap into this kind of information, whether it's a state level, a national level, or even at the international level. So our view has been to think about, well, what data can exist at the global scale in real time across all geographies? And so we've been thinking about this concept called the digital phenotype for a few years now, this idea that our digital exhaust, all the information that we stream on the internet, what we search for, what we like, and I know this is a little bit more complicated with Facebook right now, but the idea, of course, is all that data, and that data, just like it's been tapped into like by Cambridge Analytica, is also being thought of as a public health resource and really as a global good. So the data that we connect to on social media and search for and what our wearables say about us can have all sorts of insights, whether it's about food poisoning in a population, an example, about understanding about chronic disease and people's attitudes and beliefs towards their disease. Drug safety, for instance, we've worked with the FDA to build social media mining tools to get new insights about what adverse events are emerging in populations, and also getting insights on health behaviors that you would never get access to as a clinician or through any sort of more traditional channels, like around drug diversion and abuse. And of course, patient experience as well. Huge amounts of volume of data about people's healthcare is being channeled through all these different sources of information. And our thought is, well, why not start tapping into this? Why are we tapping into clinical sources when all this data is emerging across all these channels that patients are already talking about these issues? So given this concept, we've been trying to think about developing tools that sort of tap into that wide array of digital data. And in order to do that, and I don't have time to get into sort of the underlying methods, we developed taxonomies and machine learning tools that take all that vast amount, a huge amount of data, and start to tag and filter, annotate, geocode, all that information that relates to health-related concepts. And from our perspective, there are many good examples of this, which I'll get into. That information collectively can give us really incredible insights about what's happening in a population. So the idea that someone is mentioning something about an unusual event in a particular location or symptoms that they're experiencing, that collective data can give us new insights. It can also give us insights at the global scale where we don't necessarily have great intel, or if, for instance, there's limited public health infrastructure or internet freedom. So we've been trying to push this concept of digital disease detection, the idea of harnessing online data for the purpose of really advancing our understanding of population health and public health events. That first effort was around a tool that we developed some years ago called Health Map, which essentially is a global surveillance tool tapping into news and local public health sources, as well as social media, to provide this real-time view of what's happening. So that was our sort of first effort at trying to understand how to build almost like a weather map for disease and make that available, and use that data to start feeding into models that allow us to predict what's happening in a population. There's, of course, talk about swine flu. That was sort of a first example of how these data sources could play a really incredible role. The idea that local news media was talking about an unusual outbreak in Veracruz, Mexico, well ahead of government agencies talking about this issue, provided that first early warning of something happening. But even more importantly, the idea that we could tap into all this incredible wealth of data through both ministries of health as well as online sources meant that we could actually watch a virus as it spread from country to country in real time. So we were not looking at this data retrospectively, we were actually watching a virus unfold going forward. Now, there's been incredible advances in data and technology since the time of H1N1. I know that isn't even that long ago. I know we're talking about 1918, but even since H1N1, we've seen a change in communication. So there was some discussion about H7N9. If you think back to over a decade with SARS, where we had very limited information about what was happening in China, and very slight trickle of information about what was taking place, now with H7N9, we get incredible data from a place that doesn't necessarily have the most internet freedom, but even by tapping into social media sites like Weibo or WeChat, we are actually collecting incredible amounts of data, even to the point where we're concerned about issues around privacy, people taking photos of electronic medical records and posting them to social media sites. So then when it comes to the emergence of Ebola, it's very clear that there's opportunities to really understand what was happening on the ground by tapping into these vast data sources. And even in a setting like West Africa, where the amount of data we collect generally is nothing like what we would collect in the United States, the organization of that information across NGOs and clinicians on the ground provided a window and a picture of what was taking place in real time. Again, something that no particular agency could do alone. So it's this aggregation of all the vast amount of information that exists online that provides us this view. And importantly, this data can then feed into models. It could then connect to, for instance, understanding of the impact of what transportation networks might have on the movement of cases. So it's not only just looking at the surveillance data, it's integrating this data with transportation network information that allows us to understand where we might see importation of cases. It also allows us to connect with environmental data sets so we can actually have an understanding where we might see future introductions of Ebola by combining environmental data that allows us to develop niche models of future introduction. Okay, taking things a little bit more locally, I assume most people here use Yelp, and I'm sure if you're in North Carolina, you're using Yelp to see which place to eat barbecue, I would assume. But many people also use Yelp to talk about food poisoning. And actually, 10% of all Yelp reviews are related to diarrhea, surprisingly enough. And so what we've been looking at is thinking about the consumer. And I know there's this concept, oftentimes, traditionally in public health, that the individual is not a good indicator of what's actually going on with them. And what's amazing is that we started doing studies off of data, for instance, Yelp, trying to understand ingredients that consumers were talking about that were implicated in their poisoning. That data combined to CDC data reflected incredible correlations beyond what we could have imagined in terms of what consumers were saying was implicated in poisoning and what was actually confirmed by CDC. And so that led us to believe that there's even more opportunities. And so we've been building, in fact, for local public health, a tool first designated around foodborne surveillance, which essentially taps into social media and people's discussions, and maybe not in this audience, but there are millions of people tweeting about gastrointestinal disease online, but allowing for public health to actually engage back with consumers. We always have this issue where public health is monitoring off of data from electronic sources. There's essentially no customer service when it comes to public health. Taco Bell will respond to me on Twitter when I complain about something, but public health agencies don't communicate that well with constituents. But if we build tools that essentially allow us to tap into when someone complains about something and give a tool to a public health agency to immediately connect back to that individual and send them to a survey, all of a sudden now we've had this ability to engage, but also basically direct resources and interventions. We've thought about this, of course, in larger scale around influenza. We run a program called Flu Near You. And this, again, is this idea of putting the public back in public health, or citizen science that's really emerged as a tool in many different disciplines. From our perspective, there's very complicated, expensive flu surveillance systems that exist that are also, of course, important. But why don't we just ask simply the population of how they're feeling and collect data directly? And so our view has been, why not send these a weekly survey out that takes a few seconds for someone to report on. We get very detailed data about demographics, vaccination status, geography, and from there we can actually build up an incredible picture of influenza that couldn't be done with any particular existing system alone, and doing it for a fraction of the price, because we have vaccine data, we have very detailed demographic data, the individual level that you couldn't get out of any one single public health system. And so the data, of course, has been validated several times against more traditional systems, but once again, we get much more refined data on demographics and geography. Our view is that there's many other tools that can be developed, and it's actually a really exciting time to think about new technologies to support public health surveillance and intervention. This is one other example. We developed a tool that said, well, if it's really hard to engage people to tell us about their symptoms, why not start developing a tool to help a family understand what it means to have a fever and associated symptoms. So we give guidance back to individuals from Boston Children's, real guidance about what to do and dosing instructions. But on the back end, we collect incredible data about symptoms and fevers at the geographic scale that also now is feeding into our surveillance systems. We are now then thinking about, of course, the major onslaught of wearables and tools that are out there. I don't know how many people here have a connected thermometer at home, but that represented a huge opportunity for us. So it's like, well, why not start pushing that data into surveillance systems as well? Give guidance back to individuals about what it means to have a 103.4, but beyond that, actually collect real data that can inform public health. And so there's many, many tools that have emerged. There's one-off temperature sensing devices and then continuous temperature sensing devices. All of these now are connecting to some of our tools where data can be collected at population scales. We also think that there's bigger opportunities in engaging with consumers. There's only so much a public health agency can do in terms of answering the phone or how much volume an ED can handle. But chatbots are hugely scalable. And so and I don't know how many people interacted with a chatbot. You probably have, you don't even realize you have. But online, there's some great tools that you can start to interact with that are sort of the WebMD of the future. It's not going to WebMD and every answer is a cancer diagnosis. It's actually something that's highly refined and identifying through a set of questions that are iterative and based on your answers to actually a diagnosis, or at least a triaging of an individual. And what's amazing is we've implemented some of these chatbot-like conversational tools in the ED, and what we're seeing immediately, even early days, the triage and diagnostic accuracy of these devices are incredible, and they're only going to get better over time. And so the question is, how can public health start to engage with some of these technologies? Beyond just text messaging, which of course makes a lot of sense, and I'm sure a lot of people do this, there are other new tools that are emerging that I think maybe they're too forward, but we should probably start thinking about them. Websites, very 2000. Mobile apps, very 2010. What's really going to be take off, if I had to make a prediction, is voice-related technology. So voice-forward tools, there's no screen, it's just a digital assistant in your home. I don't know how many people have an Alexa here? Or actually, that's pretty good, almost, I don't know, 40% maybe. So what we think, of course, and what we've seen is the emergence of these tools in homes is really incredible, right? The idea that you have this always listening device in your home that can answer basically anything and really takes away the barrier for entry. My kids can ask questions to Alexa. It really, anybody who's interacting with these tools can access it. And what we're seeing is searches are going to be very much driven by voice going forward. And of course, just based on this audience, I think we'll be well beyond over half of US households having a smart speaker in the next few years. From our perspective, and this could be done with Amazon or Google, Siri, whoever else, we went to Amazon with this idea, well, why can't we start to make Alexa smart around healthcare related questions? And so we built the first health skill for Amazon called KidsMD. Essentially, you can ask it about acute conditions around your kid, fevers, asthma, various different discussions. And once again, we can start to engage with consumers, give them help them make better decisions, again, on the back end, having much better access to data about what's happening at a population level. And so there's no reason to get into the architecture, but essentially someone goes and asks Alexa about something like a fever, that taps into our knowledge repository. It uses machine learning tools to give back an answer to that individual. Of course, we're also thinking about how to take some of these tools and push towards better access. We've been working for many years, and actually with Bruce and Lisa Kunin for many years on this idea of how do you build technologies to give better access to individuals, say around vaccines. So we've been running the Vaccine Finder project for many years now with this idea that there's all this capacity for vaccines, but people don't know where to go, how much things cost, and so we provide a knowledge base of all the tens of thousands of locations that are out there for someone to access a flu shot and many other vaccines as well. And as a spin-off of that information, we've actually been building a MedFinder, Flu MedFinder, that is essentially the same concept, but around giving access and insights to consumers about where to find antivirals. And you can imagine that in a pandemic where you have people scouring from pharmacy to pharmacy, that is sort of not the kind of user behavior that we're looking for. And to give people very clear guidance where there's availability, where there's low supply, especially in a real major pandemic event, is such a clearly needed effort. So this is an area that we've been focused on, this concept of bringing in providers into this network that essentially will be a national system, is already now, to this day, actually providing real helpful insights to the CDC. Although it's very easy to try to push people to walk a block to get a vaccine or an antiviral, right now there's a generation, of course, that has emerged that is not willing to walk a block and does not want to get a vaccine if it is an inconvenience. So our thought was, well, if it's so challenging to get someone to do that, well, what if the vaccine just came into your own home? Will you then get it? And it turns out that the answer is yes. People are okay with that. So we developed a concept called Uber Health, where we this was over many legal discussions with Uber to put vaccines in a car and offer. It wasn't giving people flu shot while they're driving. This was a nurse, and then they delivered the vaccine. They brought it to someone's home. And we were able to do this. We've actually done this over several years now with this concept. We could put nurses, and this was really a proof of concept. Can you use this massive logistics network that exists at Uber to essentially deliver vaccine? And we're still thinking about how one scales these type of approaches, but what's exciting is that you're accessing a part of the population that is not looking to get a vaccine. It's not because they're opposed to the vaccine, it's just because it's not convenient. And if you can get your food delivered, you can get anything delivered, why shouldn't it also be your healthcare? And so what we're seeing is, and when we did surveys after this, we could access huge parts of the population, well, subsets of the population based on the fact that it was convenient. And convenience actually is a huge driver for people in their decision to get a flu shot, it turns out. So if you make it that simple, you make it a button press, then it turns out people are willing to do it. And it's not really about Uber specifically, Lyft, Amazon. All these companies are actually getting into this space, and there's a whole sort of ecosystem of companies that are emerging that are thinking about healthcare logistics. We're even working on a platform that enables sort of a full exchange of how you think about product delivery, how you get patients to the ED, but all how do you help facilitate discharge. But there's all sorts of new opportunities emerging. So I'll just try to close with a couple things. One, there's no reason why someone ever has to come to the ED. If you think about it, there's technologies, autonomous vehicles that will essentially enable someone to get their care and receive a diagnosis without actually having to interact with a human. That might be scary to people, but it's going to happen. And of course, when you actually want to deliver that vaccine and antiviral to that individual, you can just send the autonomous little bot. This is developed by the scooter company Piaggio, and if someone's too far, then you can just, of course, send a drone. And so, you know, there's still a lot of limitations. This is a company called Zipline that's doing incredible work in resource-poor settings to deliver vaccines. So this is not like pie-in-the-sky stuff. This is actually happening today, right now. So there's all sorts of incredible technology that we can begin to leverage. So huge opportunities in this future on-demand world, maybe too far for today's discussion, but of course we think from a public health perspective, huge opportunities around using these existing tools, so not developing new technology, but harnessing existing companies, existing infrastructures to essentially deal with, you know, major events as they unfold. So I'll leave it there and look forward to our discussion. Thanks.
I've seen a lot of great slides today. I was looking at them and said, "Boy, these are really great slides." I can tell you right now, I have no slides. I was trying to think, what do I got to come up with a slide talking about bioterrorism and that? I mean, you know, except maybe some horrid stuff up there, and I decided, well, maybe I won't be doing that. But I have been working in the area of bioterrorism for, you know, approximately 20 years, just really shortly before 9/11, before the anthrax and so forth. And one of the things that I've noticed is that, you know, I think it was talked about in terms of the selective amnesia type thing. You know, early on when we started this, there was money flowing in, there was interest. You know, early on I was doing, you know, several interviews, either radio, television, newspapers and that stuff. And then over a period of time, it's faded off. You know, people have forgotten much more about the whole idea of bioterrorism. And I think that that's understandable. I mean, I think early on there was some feelings that, you know, it was inevitable within, you know, 5 years or 10 years or something like that. Well, you know, it's been many more years than that. And so my feeling is that it is a real threat. Will it happen in my lifetime? I'm not certain, but I certainly think it will. So I would like to discuss just a little bit about using influenza as a bioterrorist agent. I think it has been brought up here as a possibility. And I'll talk a little bit about what steps should be taken to minimize the consequences of such an attack. You know, as we've learned from previous talks, pandemics occur when 3 conditions have been met. It's a new influenza virus subtype emerges. It infects humans, causing serious illness, and it spreads easily and sustainably among humans. You know, the 1918 flu pandemic is an excellent example of the occurrence of all of these conditions. And as you have learned during this symposium, it killed millions of people. The exact number is not known. I've heard several here, and I think no one really knows the number. But because this was a new influenza subtype, the population had little to no immunization protection. You know, there were no vaccines, there were no antivirals available. But today, even with vaccines and antivirals, over 40,000 U.S. deaths occur each year. That is probably a low number because there seems to be some evidence now that it also contributes to as a trigger for cardiovascular events, which make it easier. So the question I posed in this talk is what would happen if the influenza A virus was genetically altered by a terrorist or rogue nation. Unlike other potential bioterrorist agents such as smallpox, influenza virus is readily available and a candidate for genetic alteration. The 1997 Hong Kong flu shows how virulent the naturally occurring influenza virus can be. And while this was transmitted from chickens to people, a modification of this virus could make it to allow it to be transmitted from human to human. The influenza virus has a very short incubation period, 1 to 4 days. So in the event of a bioterrorist attack, there would be not time for vaccination or administration of antivirals, even if we felt that the ones we had could have some beneficial effect to the modified virus. Since influenza occurs naturally, a cluster of cases would not prompt an investigation, unless, of course, they came out of a time that when we naturally would expect that to be occurring. Epidemics would have considerable head start on public health authorities. And because of the similarities between early symptoms of influenza and other bioterrorist agents, clinicians need to understand the difference in symptoms and signs to be suspicious that this was not a naturally occurring event. You know, the population size today, as we have seen, is 7 times larger than it was in 1918, and people are living in more crowded environments. So people would probably lack immunological protection to the altered virus, and existing antiviral drugs might not be effective. This could be spread simply by the release of an aerosol spray in several crowded areas, such as airlines or subways, and then it could be spread from human to human. Now, I recognize that most terrorists would not have the knowledge, facilities, and ingenuity to carry out a recombinant DNA experiment today, but we really don't know what that might be tomorrow. I mean, we're finding that the terrorists have more and more sources of money from drug trafficking, from ransoming people, from overtaking oil fields and so forth. So they're becoming more available with money, more able to buy the services of individuals who might help them to do this. Certainly, nations do have this capacity. And what we would probably see with the nations is that there's really a fear of using a biological agent such as this because it's going to infect their own population. But more than likely, terrorists don't have that worry, as we can see by the use of suicide attackers and so forth, that that's not a major concern for them. So even without creating an altered virus, this is one that I thought was really interesting. It was really brought up by my wife. I didn't think about it, but anyway. Terrorists could possibly create a vaccine scare. You know, we know all this fake news that we're hearing about now. Well, there's many people out there that use social media, and they get most of their information from social media. So what if terrorist organization was able to really put fake news out there over the social media that indicates that the vaccine is harmful? And we've seen this historically. But what if they really push this? What impact might this have on fewer people becoming vaccinated, and therefore just the naturally occurring influenza would have more of an effect? So whatever the source of the influenza pandemic, our healthcare system would be overwhelmed, making us vulnerable to other terrorist attacks. So what should we do to prepare for a genetically altered virus or for a naturally occurring influenza pandemic? We certainly need to increase the research on the development of antiviral drugs, as been discussed today, and that these drugs need to be directed toward the function shared by influenza A virus strains that would constitute the best line of defense against a bioterrorist attack. However, this would only be effective if we had a mechanism to stockpile and distribute the antivirals in a timely manner. We know that there has been a lot of stockpiling of other types of interventions in case of some type of a bioterrorist attack or a natural disaster, but we haven't seen this type of stockpiling for antivirals, and we, as mentioned earlier, don't know if the currently available antivirals would be effective against an altered virus. But the stockpiling and delivering of these antivirals would also benefit a naturally occurring influenza pandemic, and therefore we should be seriously considering this. However, an increase in research and development, this has also been discussed, could result in other countries perceiving this as an offensive rather than a defensive effort. This fear could lead to the development of influenza as a biological weapon by other nations because they see we are working in this area, and if they believe that this is possibly for offensive use, then they will also be developing the same thing. This is what has been referred to in the literature as a security dilemma, the potential for states to fall victim to their own uncertainty about each other's intentions, creating a vicious cycle. Also, increasing research, particularly by non-government agencies, could increase the risk that an altered virus might be released into the air from a laboratory or sold to a terrorist organization. CDC could make influenza a crucial agent priority as a bioterrorist threat and list it with the other crucial agents. CDC should bring experts in influenza and bioterrorism together to discuss how to prepare, how to respond to a pandemic and a localized epidemic. I know that these types of things are occurring, but I'm not certain that they're occurring at the rate that will be necessary for us to be in some level of preparedness if influenza ever does become a bioterrorist threat. We certainly need more efforts needed to be made to immunize those of whom immunization is currently recommended, because this might be partially effective against an altered virus. I know we've talked about various methods of trying to extend the number of people who are immunized, but I think even more effort needs to be done in this area. We also need to increase the security of the laboratories conducting influenza research and of the manufacturers and distributed of the vaccines and antivirals. We need to increase our capacity to rapidly develop and produce vaccines and antivirals, all things that have been mentioned today. We need to expand active surveillance with the awareness that a bioterrorist attack using a genetically altered influenza virus is possible. And we need to train physicians to not only look for usual cluster of symptoms that suggest a bioterrorist event, but also look for the usual symptoms of influenza but symptoms occurring at an unusual time of the year, and a flu virus that does not respond to antivirals. Unfortunately, the further we get from a bioterrorist event, such as the anthrax scare, the less efforts are made to develop measures to address the bioterrorist-initiated influenza attack. Measures that were put in place, such as Project BioShield, are not receiving the attention they did in the early 2000s. We must continue to be vigilant to the potential of a bioterrorist attack or a naturally occurring pandemic by increasing the core capacities of the public health system to detect, track, and contain infectious disease. We must strengthen the relationship between medicine and public health. Medical personnel must be taught who to call if they suspect the use of an altered influenza virus. Public health and medical care organizations must develop appropriate policies and training material. Development of emergency plans for the surge capacity for patients in hospitals. Enhanced systems to stockpile mass casualty conditions, such as stockpiling antivirals, which I'd already mentioned. And develop methods to rapidly distribute the antivirals. Prioritization should receive the antivirals. Who should receive them? Should it be the old, the young, the pregnant, the diseased? And these need to be decided in advance of when they will be needed. So federal planning is important, but the response is local. Therefore, we must build capacity and local health departments. Most significantly, we must bolster our intelligence so that we can prevent an attack before it occurs. Now, all of these things that I mentioned, these last ones, are things that have been out there for all types of bioterrorist attacks, not just influenza, but all other types of terrorist attacks. So all we're doing is extending those ideas to the whole idea of the potential use of influenza. So influenza might not be the most potent bioterrorist agent, certainly not as potent as anthrax or smallpox, but it has the potential of infecting more people in a relatively short period of time, as evidenced by the 1918 pandemic. Everything that we do today is more difficult because terrorists are familiar with our preparedness efforts. In the words of Margaret Hamburg, it may prove impossible to prevent future bioweapon attacks from occurring, but planning and preparation could greatly mitigate the death and suffering that would result. As a nation, we need comprehensive, integrated planning for how we will address the threat of bioterrorism, focusing both on prevention and response. Now, these words were spoken in 2002, are possibly even more important today with the advances made in genetically altering viruses that could lead to the next flu pandemic. And of course, preparing for a potential bioterrorist attack using influenza will also help us to prepare for a naturally occurring flu pandemic. Thank you.
Good afternoon, and first of all, I would like to thank the organizers for the invitation to present at this good event, amazing event. I note, however, that as an economist, I got put last, so everybody can move out. Been there, done that. Death, doom, destruction, and even dead ferrets. So today we've heard a lot about how bad influenza pandemics can be. So what can we do about it? We've had some ideas. We've had some great ideas from John earlier in this session about using the magic of the interneting thing to plan and track it. But there needs to do more, as Dean Evans mentioned. What can we learn about when we first look at the history of pandemics? 1918, as everybody knows, wasn't the only pandemic. It stands out because it was so large, but it wasn't the only one. We learn, as this graph shows, that pandemics start or occur between 10 and every 60 years. And that's a bit problematic because if you tell a lot of politicians that the next pandemic might occur in 60 years from now, they'll go, I will not only be out of power then, I will be dead. But it could occur next year. We don't know. Of course, we've had a lot of talk about the pandemics. The other part, though, is what impact will the pandemic be? The problem again arises as there's a great deal of variability. We can't guarantee that there'll be X number of dead bodies stacked like cordwood in the highways. There will be deaths, but cannot guarantee the numbers. Also important, and perhaps even more important, it matters who dies. In 2009, there was some criticism that the WHO and indeed the CDC called it a pandemic when the number of deaths were, to be honest, less than some of the bad seasonal non-pandemic flus. But if you look at this table here, this part here circled in red, the rate of deaths amongst children was 8 times that of what we typically saw in the 1990 to 99 period. 8 times. Anybody who says that 2009 wasn't a real pandemic, I have 2 questions for them. How many children must die before you consider it a pandemic? And B, how did you pick the number? The other part that was interesting in 2009, and nobody really expected, anybody says, oh, I foresaw this, is to use another speaker's terminology from earlier this morning as a liar or an idiot or both, is that the deaths amongst the people over 65 was only about a quarter of what you typically saw. The old people didn't die like they were meant to. That's a good thing. And this was due, apparently, to previous exposures and strains in the late 1950s with perhaps some additional exposure in the 70s. Who knew that exposure in the late 50s would provide sufficient immune response in 2009 such that their death rate would be much lower? Couldn't guess that, can't plan for that. We've had some mention of the macroeconomic impacts. On the left up there are some estimates from McKibben and Secondo about the potential drop in gross domestic product. I promise you that's the only economic term I'll use in my talk. Around the globe, to put it in context, moderate to severe, the 2008 recession was around about this much for the US, between 1% and 3% loss in GDP, whereupon an ultra, and you've seen the figures before, we'd see somewhere around a 5 or 6% drop in gross domestic product. On the right are some estimates we did back in 1999, been doing this for a while, we asked the question, what if a 1968 pandemic, which is the least severe from the 3 pandemics in the 20th century, what if that were to occur today? And we get an estimate of about $170 billion, this is in 1996 dollars, with a maximum of about $250 billion, and that's without accounting for the economic disruption, the loss of business. That's mainly due to the value of lost productivity due to premature deaths. Okay, those numbers can seem impressive, but what do they mean? What can we actually do with all those death, doom, destruction, loss of economics? Well, we can do a couple of things. We can plan and prepare. It's been emphasized already today, and rightly so. I don't believe we can over-plan or over-prepare for an event such as this. We need to have some estimates, planning. Even if they don't occur, you can't plan without numbers. Planning is everything. Plans might fall apart at the first contact of the enemy, but if you don't have plans, nothing's going to be done in time or anywhere close to addressing the problem. As mentioned by Dean Evans, we have to consider now what are we going to do about shortages and who goes to the front. Essential. It's a really bad idea to have this discussion the day the pandemic arrives. Stockpiling, absolutely essential, but it's also a truism that we can't buy our way out of this problem. We can't put enough in the stockpiles. We can't get it out of the stockpiles and rapidly distribute it in time. It helps, but again, it's not going to be the sole solution. We also have non-pharmaceutical interventions. Let's take a little look at planning and preparing. This is a graph we produced back in 1999, estimates of the number of deaths, emphasizing the uncertainty. On the x-axis is the percentage of the US population that become clinically ill, those with symptoms, anywhere from 15% to 35%. Can't guarantee the percentage. And on the left, the x-axis is the total number of deaths, and for any given gross clinical attack rate, there's a wide range of potential deaths. You all know what the media picked up, right? Down in the bottom left-hand corner, though, are numbers equivalent to a severe seasonal influenza. So it could be anywhere in between, and we have to adapt our planning and understand that we could have a pandemic that fits in anywhere between that. As an economist, of course, I put dollar values to vaccination, the values of life, etc., and came up, what are the net returns to vaccination? So this graph, set of many graphs, shows that, first of all, there's always a positive net return to vaccination. This is actually unusual in public health. Prevention doesn't always save money. This is the one of the few examples where it does. What does differ, though, is that the returns to investment from vaccination against influenza pandemic depends upon age group and whether you are in a high-risk category or not. Now, high risk does not mean you're at high risk of getting the disease. It's of high risk of bad things happening to you once you become clinically ill from flu because of pre-existing medical conditions such as emphysema, cardiopulmonary problem, or indeed, ladies, pregnancy. If you are pregnant or planning to get pregnant next flu season, please get your flu shot. Clearly, there is a difference by age and risk group of the returns. Happily, it's all positive. But, as has been mentioned already, the current technology, and this is true for the past over 20 years that I've been working on this, we cannot assume today that if there was a pandemic this year, that we would be able to produce enough vaccine to vaccinate the vast majority of the US population ahead of the pandemic arriving in the typical flu season. We would have to make the decision of who goes to the front. Here's but two examples of criterion, because it's single, that you would use to prioritize who goes to the front. In the first column, we have risk of death. And using the 1968 type of scenario, it would be granny and grandpa would go to the front because they have, using 1968 data, the highest risk of death. But if you use the idea of continuation of society, making sure that society continues, nuclear engineers that run the power plants, there's only so many of them, critical. Can leave out perhaps Homer Simpson, but the rest, perhaps you'll put them to the front. We even might worry about, what about the children at high risk? Those who had children and teenagers, you wonder what their return to investment is. They seem to consume genes, all sorts of techno-gadgets, but they represent the future, so perhaps they should go to the front. And then there's a whole bunch of other people that make society and are needed to make society run during a pandemic. The physicians, the people who even drive trucks that deliver food to the supermarket. Perhaps they should go to the front. If you are the Secretary of Health and Human Services for the US federal government, you have to make a choice. And somebody will point out, yes, you can have different columns, different criteria. Sure, you can have hundreds of them. A lot of those potentials are dropped because they're not feasible for one reason or the other. And indeed, in 2009, what happened was that these two columns there was a mixture. They mixed them together, and that's fine. But the worst thing to do is have this kind of discussion about who goes to the front the day the pandemic arrives or the day the flu vaccine starts to come off the line. You have to plan and prepare because, quite frankly, this is a shock to many people that we have to ration. We're not used to it. We need also a lot of more planning and preparing. Simple tools, these are the ones that we've produced. They could run on a spreadsheet. They're designed to use by state and local pandemic planning committees. They have been downloaded since 2000, about 130,000 times, so they've been used. There was a spike, no surprise, in 2009. I personally have a personal worry that since 2009, there's perhaps been a little easing on the brake pedal, a little less attention to this, and we need to renew the effort in planning and preparing for the next pandemic, for it will surely come. Stockpiling. Yep, definitely need that. Here's an example back in 2013 when we were planning, preparing, what if H7N9, which we were all suitably scared earlier today, and we should have been, could have spilled out into humans and been the next pandemic, and probably would have been very nasty. Mechanical ventilators. How many would you need at peak? And here are some estimates, and there's estimates ranging on original set of assumptions and then sensitivity. And the difference is how fast does it transmit? If the disease transmits very quickly, you'll have a lot of people in a very short space of time appearing at the hospital requiring mechanical ventilation. And at a 30% attack rate, some of our estimates suggested we need 140,000 units, mechanical ventilators. Okay, problem solved. We'll put it in the stockpile. No more problem. We like to put things in stockpile. They're tactical. We can sense them. We can have pictures. We can put it on the web. We can touch it. Trouble is, it's only part of a system. In the box, mechanical ventilators save no lives. They've got to be taken out of the box and applied to the patients by a very experienced and very technically highly trained team of medical providers. And what we found when we looked at the idea of just what is the capacity for our healthcare system in this country to absorb and use additional mechanical ventilators, we found there was a lot of restrictions, all to do with personnel. Physicians were less of a problem. It's a funny statement to make, isn't it? Physicians are not the problem. Things like beds, and in this case, even when we go to crisis capacity level, thinking of every single way you can shoehorn and squeeze patients in, reduce perhaps even the quality of care, so long as they can get a mechanical ventilator, we find that the number of respiratory therapists, not doctors, respiratory therapists might be the limiting factor. These are the factors that are going to really determine how much of that stockpiled stuff we can actually deploy and use effectively. It's not just putting stuff in a stockpile, it is how do we use it. Which brings us to a very strange word for an economist, ethics. I always need to rinse my mouth out. You need to sort out a front about who is going to get these limited resources, particularly in a time of high stress and strain. People are going to come to the emergency room and say, my granny, my mother, elderly, hard time breathing, needs a mechanical ventilator, and somebody's going to say, yeah, but she's only got a 10% chance of living if we put on it. We've got to keep the one surviving, the one spare one that we have at the moment for the 23-year-old that's going to come in the next 24 hours and will have a 50% chance of surviving. How many physicians in an ER are willing to take that stand and stand in front of a family and say no? Conversation you need beforehand. Some work has been done, but this is great work, but it's not living. How do you translate what's written into action? Got to plan and prepare for it. Non-pharmaceutical interventions. Oh boy, are we going to use these. During 2009, we actually had a chance to do an unplanned but living experiment, school closures in the Dallas-Fort Worth area. One school district closed its schools in April, late April, early May, and the district next to it didn't. And as you can see, when we made adjustments for the weekend and for the 2 to 5 day incubation period, in the yellow, this is when the school was closed in one district. The district that closed schools, fewer students, 6 to 18, went to the emergency room for influenza-like illnesses. Yay. But notice, the moment they hit the switch off again, school's back in, the difference disappeared, and in fact, the district that closed schools had a peak of kids suddenly turning up at the emergency rooms again. So what we learned from this is that school closures can have an impact, but it can be very limiting, and the moment you bring the schools back in again, expect the flu to start circulating amongst those populations. And another thing, that impact is not necessarily equal amongst all age groups. This is the same situation, but looking at 19 years and older, and as you can see, no difference. So this is not a one-size-fits-all. All we have to do is close the schools and everything will be okay. Note this is for only 1 week. We did some modeling as well, particularly based on the 2013 H7N9 preparations, just in case. And one of our group looked at what happened on the impact of school closures versus delay in time to peak. And what the idea is, you close schools, and it delays the peak of the pandemic, allowing you more time to produce vaccine, deliver it, and immunize people before the vaccine starts to the strain of flu starts to really circulate. That's great, except it's not inexpensive. As you can imagine, if you want to delay it by about, say, 120 days, you're going to have to close schools for about 140 days. Yeah, people are already imagining how that'll go down at the local PTA. Not. Going to be very difficult to explain to parents. Yes, you need to close the schools. And by the way, that doesn't mean close the schools and let them run feral and wild in the malls. They've got to be staying separate. Very, very difficult. And it's got to be done early. Do you see that all of these start closing schools at the very, very early stage? Less than 1% of the population has to have the disease. You have to stop it. It's no good. If you start closing it when 5–10% of the population close, you might as well not do it. We did do some studies back in 2009 of the economic impact of households in places that closed schools. This is the one from Pennsylvania, where schools were closed for about a week, elementary, semi-rural Pennsylvania. The vast majority of households stated that they had zero impact of workdays lost, which is obviously one of the biggest economic impacts for households. Why am I worried about households and the economic impacts of school closures? Because this is the machine that ensures that schools will stay closed and that parents and families will adhere to keeping kids separated. If this school closure thing becomes too much of a burden, there'll be less and less compliance, less and less willingness for school districts to do it. So this sounds kind of great. No real economic impact. And by the way, we did this in New York City. We even went down to Argentina, where they had two cities that closed it for longer, found similar results. But this is short term. This is 1 week. What if we said to the families in New York City, it's closed for 100 days? I wouldn't want to be the mayor that stands up in front of the New York Post and mention this. It could be kind of volatile. We have to address this issue before we can say this is definitely going to be used. Summary then on school closures. So non-pharmaceutical intervention, school closures, it sounds simple. In fact, there's a lot of issues to be resolved and sorted out before the pandemic, before we're sure that this will really work the way it potentially can. Finally, we get to the idea of non-pharmaceutical interventions of businesses. I mentioned already making sure that society runs, carries on moving. Businesses and even hospitals need to plan for the fact that they're likely to have sick staff. One of the programs we looked in, one of the papers we produced was estimates of the percentage of workdays lost at the stage of the pandemic. We modeled an 8-week pandemic for a given society. And you say, well, gee, that doesn't sound much. 5, maybe 7% of your workforce at maximum would be out in a given week. That doesn't sound much. Ha! Imagine, for those who run hospitals, 7% of your nurses are out 1 day, 1 week, not just 1 day, 1 week. You're in the middle of a pandemic, where are you going to get replacements? Those companies you phone up that have temporary locum nurses and physicians, they're going to be out. What are you going to do? Do you have a plan? What happens if it's all the 5 key people? What are you going to do? It's not so much to say society will collapse. It's so much to do with a warning that you need to have a plan to figure out how you're going to rotate staff and what you're going to prioritize and what is going to be put to the side until the pandemic's over. So, in summary, what can we do? Pandemic's definitely coming. We need to plan and prepare. We can't guarantee, unfortunately, about when it will happen, and we can't guarantee about the size or the impact, except that it will come. We need to plan and prepare what will be done and why, and that means a lot of engagement beyond just a few people in a room in the public health service doing some talking to each other. Communities, physicians, frontline healthcare givers all need to be involved in this type of discussion. Thank you. That'll be all.
Would the panelists please come up, and we'll have a short time for some questions. It's been a wonderful day and a long one. And the last panel provided some very provocative ideas for us to think about. We have microphones on the side of the room. I'd like to invite you to come up and ask questions. Unfortunately, we cannot take questions from our online viewers at this time, just those in the room. And I'll ask that you're succinct. We are going to allow a couple of minutes for questions, and then we'll adjourn before our evening's festivities. Please.
I'm Marcia Walker, and I have a question about bioterrorism in the context of informational terrorism. So I loved the presentation about the Yelp data versus the actual data, and that just blew my mind. But someone could very easily do fake data. So someone could send fake signals like from Africa or fake signals from a city to distract the government to be doing things when the real threat is coming from somewhere else. So how do you guys take into account informational terrorism in the context of bioterrorism?
It's a great question, and it's good we connected on Twitter. That's how you session. But I think it's something that we've always thought about from one of the beginnings of the system. We've always been looking for sort of injection of fake news, before I guess it was called fake news. But it's actually on the public health side, it's been very rare. I mean, we've seen it a little bit on the smallpox front. But we have human curators that are constantly looking at the data as well. So we don't just do fully automated approaches to organizing information. Also, we're not necessarily building signals off of one, unverified social media account. There has to be an aggregation of multiple. And of course, you could sort of say that an army of hackers all pushing in a particular signal at once, and that's definitely a concern. But again, we sort of rate information sources very differently, right? So vetted news media is going to take on a very different type of signal than, again, unverified social media accounts. But again, we haven't yet seen this in real life yet on the public health front. It doesn't mean it's not going to happen, and so we're pretty acutely aware that we need to pay attention to these kind of things.
Thank you very much.
Comment and a question, if I may. Fred Hayden, University of Virginia. So healthcare providers have been impacted early and often in events like MERS, SARS, Ebola, even 1918 pandemic influenza. So the question is, are there existing surveillance systems in the United States or elsewhere to specifically monitor events in healthcare providers, physicians, nurses, respiratory therapists? Is an early warning system for a novel introduction?
Mark, you want to start? And then John?
There are professional networks that exist. So I didn't have a lot of time to talk about it, but of course there's ProMed, which is actually a system that we run and have supported for many years. That's a social network of mostly healthcare professionals, and those are the places where you would see some of those discussions. We also run a surveillance network called EpiCore, which is actually a network of trained epidemiologists and professionals that are tuned to sort of providing these kind of things. I mean, what you're saying is a little bit more on the syndromic surveillance side, potentially. That I have not seen. The idea that someone is specifically collecting electronic data from healthcare professionals looking for a signal and symptoms. That doesn't exist specifically. Of course, those populations are lumped in with other surveillance systems, but it's a good idea.
All right.
It's Barney Graham from NIH. I have most pandemic threats begin as regional diseases. It's maybe not true for flu, but most pandemic threats begin as a regional problem. And so my questions are for surveillance. Are these systems set up in the places where these kind of regional diseases usually emerge, which are developing countries, or are they all set up in places where the disease moves? And the second question is, how do you motivate people to invest in monitoring and preventing and working on and pre-pandemic preparedness for regional diseases?
Barney, let me start, and then others will comment, but we might want to feed that question to Dr. Frieden, who's been involved in a lot of that, and he participates with us tomorrow by video conference. I made a reference to the Global Health Security Agenda, which came up after the international health regulations with the recognition of that very fact, that it's the weakest link in the chain is going to be the problem, and this is really a program that's really designed to look at those places in the map where things are not as strong and to strengthen those capacities. The slide had the 10 or 11 areas of capacity strengthening, but that whole program was designed to address the very issue you raised.
So it is actually, I agree, the international health agenda is become very much in the fore. Actually, I think Ebola is very much brought to the fore for politicians and the general public, that there is a need for not only just for surveillance, but response. Surveillance by itself is worthless. It's got to be tied to a rapid response, and that obviously didn't work too well, to say the least, in Ebola, and has changed a lot of people's opinion. So I think now there's been and I'm working with a lot of groups, including WHO, in working on various ways to strengthen it. One of the greatest needs right now is just the estimates of what does it cost to expand surveillance and response. It's the first thing that governments, as you can imagine, of developing countries with strained resources said, okay, this sounds like a good idea. We have good ideas by the dozen dropped on our doorstep. How much will this cost, and what will it actually look like, and what will it do? But it is happening, whereas before, less so. So I am hopeful and confident that it will improve over time.
Thank you.
Jennifer Smith, UNC Epidemiology. I have a question that actually relates largely to the previous question, which relates to the global health. And John, you referred to Uber Health, and I take Ubers when I'm in Kenya, and I'm just wondering a general idea about private sector involvement in future prevention, and what that could look like, and what would that look like with an Uber that is, or with telecom, and what do you think the future can be in terms of looking at private sector, in terms of helping countries, particularly those that have those private industries there that are actually, what are they doing in terms of giving back for prevention?
Right. No, it's a good question, and I think a lot of the number of telecom companies have been involved in certain efforts around cell phone-based participatory surveillance systems, and I think there's been some movement. Frankly, it's a lot of years of trying to convince the private sector to care about public health and to invest in it. We're seeing some movement now on the part of many of the Silicon Valley companies investing in healthcare and thinking about making data more available for patients, and so you've seen a lot of movement with Google and Apple recently. Facebook's got a little bit of another issue that it's dealing with right now, so maybe less them. So we're seeing a little bit locally, we're seeing some of that, but I would say not nearly enough. There has been some efforts to try to create these bridges between public sector and private, but for me personally, in trying to get more global attention, it has still been a challenge. But I don't
Just one comment. I think that over the past several years, the World Economic Forum, the Davos people, have picked this up as a focus area. And I think it's a combination of maybe corporate self-interest, because these multinational companies are in these places, social responsibility, and these are the kind of people who think they can change the world. So I think those things are all good. And there is there's a new stream there within the Davos crowd to take a look at these kind of problems.
Great, we have time for a couple more questions.
I'll ask another one if there's no one else waiting. It was around privacy, and I think it was biosurveillance guy, I forgot your name, sorry. You showed a slide where it was EMT data, and the woman said, I came from Brazil, and I'm pregnant, whatever. And I always like to think of what could go wrong with human behavior, and I would think an immigrant population that learns that that's what's being done might say, hey, I'm not gonna call for an ambulance anymore if I get sick, because they can identify that I'm an immigrant from another country. You know what I mean? Well, how are you guys taking those kinds of concerns into account of people like just going off the grid in order to protect themselves from a privacy perspective?
So, I mean, I think that'd be no different from going to the emergency room to report, and you're always going to get history and such taken for that, and case finding that's been done by epidemiologists for years. So I understand the issue, but I don't think it's any different than privacy issues that exist in healthcare. You know, you just have to have the right HIPAA and firewalls that are built in there to ensure privacy is there, I think. I mean, we've seen people posting gastrointestinal distress from different restaurants on Twitter, so I think, there's different issues like that.
Great. All right. Well, it looks like we've come to the end of our session, and please join me in thanking our panelists. I'd like to give a shout out to you, the audience. You've been extremely thoughtful and collaborative throughout the day.